Brissette. I'm a cornea, cataract, and refractive surgeon at Weill Cornell Medicine in New York City, and I'm going to be presenting today about optimizing outcomes in dry eye management. So thank you so much to the Eyes on 22 team for putting together this virtual conference. It's so exciting to be a part of it and a new way that we're doing things in ophthalmology for 2022. Financial disclosures that I have here, they're all listed here, and consultant for the following companies, and I do research as well. This is our dry eye talk. So basically, dry eye disease can be really complicated, and our understanding of it is continuing to progress. And there's multiple studies that have been published over the past number of years, really looking at the pathophysiology behind dry eye disease. And the pathophysiology itself, as I mentioned, can be complex. Just looking at this graph here, starting to think about things like ocular surface inflammation, the effect of the meibomian glands on the ocular surface. So this can seem like a really daunting task to really try and understand ocular surface disease, and specifically dry eye disease, and how to treat it. But our treatment options can be simplified, and there really is a wonderful way that you can start to organize your treatment plan for patients so that you can, one, involve the patient in decision-making about their care, and two, start to really simplify and streamline efficiency in your clinic so that you can see these dry eye patients, you can educate, and you can come up with a treatment plan that's specific and customized to them. So when you see this kind of cycle of dry eye disease, which we'll talk about later in the talk, I don't want you to be overwhelmed by all of these terms and inflammatory markers. Really just getting to the bottom of it is getting to the root cause of the inflammation and then treating that inflammation on the ocular surface. So dry eye disease is defined by loss of homeostasis on the ocular surface, inflammation, hyperosmolarity, and then leading to neurosensory changes. And this definition comes from the TFOS-DUES-2, which was a publication from 2017, which really looked at the underlying causes of dry eye disease, treatment options, and especially this neurosensory pathway and changes that can occur with dry eye disease. So the loss of homeostasis we know occurs due to underlying inflammation. And as I mentioned before, inflammation is the root cause of dry eye disease. So treating the inflammation is really necessary in terms of getting these patients comfortable, getting them seeing better, and improving their symptoms and signs of dry eye disease. Hyperosmolarity is pathognomonic for dry eye disease, and we can actually measure the osmolarity on the ocular surface using point of care in-office tests. So we have the tear osmolarity test, which is by Tear Science, which can do measurements of osmolarity. And you can actually use this as a metric to follow along somebody's osmolarity improving over time as they're on treatment options. And then lastly, the neurosensory changes is something that's becoming more important to start to understand about the pathophysiology of dry eye disease. You know, we always talk about these patients that are pain without stain, so they don't have any signs of dry eye disease when you look under the slit lamp, but they're complaining bitterly of discomfort of the ocular surface. And that's often due to chronic inflammatory changes that can change the nerve structure within the cornea. So the neurosensory changes did become a part of the definition of dry eye disease. So just remember, it's the loss of homeostasis due to inflammation. You also have hyperosmolarity on the surface, which you can actually measure in office. And then lastly, neurosensory changes if it's been there for a prolonged period of time. This is some new information that we have about the ocular surface and the tear film. So in the TFOS-DUES-2 publication from 2017, they really started to rethink about the tear film as being a two-layered interactive structure that has both a mucus layer and an aqueous layer that are somewhat combined. And the mucoaqueous layer serves to reduce the friction and also helps to provide hydration to the ocular surface. And then lastly, the lipid layer serves to reduce the surface tension and also minimize evaporation and tear film instability. So both components of that two-layered structure, so the mucoaqueous layer and the lipid layer, are important for having homeostasis of the ocular surface. So you have to have all of those components treated when you're thinking about treating dry eye disease. So not just increasing the lipid layer on the surface, but also the mucoaqueous production as well. Evaporation really leads to this hyperosmolarity and inflammation. So even if you're producing tears, if they're evaporating too fast from the ocular surface, then this can lead to symptoms and signs of dry eye disease. When you have inflammation on the ocular surface, this in turn leads to epithelial damage. And those are the punctate changes that you see on the ocular surface when you stain. So looking for staining under the slit lamp using vital dyes is a really important part of the examination. And tear instability as well. So So a rapid tear breakup time might be evident as well due to evaporation from poor quality of the tear film. And then this in turn leads to more inflammation. And this is what we often refer to as that vicious circle or vicious cycle of inflammation. So you have poor quality tear film, which rapidly evaporates. That leads to inflammation. The inflammation leads to epithelial damage, which leads in turn to more inflammation. And that's why when we get to the treatment part of the talk, treating that root cause of the inflammation is really vital in terms of getting patients more comfortable and also in reversing some of the ocular surface changes of dry eye disease. Mybography has become a really important part of the examination as well, an assessment of the meibum, the expression, and the quality. So this is an essential part of the exam. This is mybography showing the components of the meibomian glands, and you can see here that some of these glands are quite shortened. The glands should be nice and long and straight, and unfortunately there's some meibomian gland loss due to chronic clogging of the meibomian glands and inexpressed meibum. So what I'll often do is I'll take a look under the slit lamp at the opening of the meibomian glands, and I'll even push on the lower lid margin to see if there's expression of meibum. In some of these dry eye patients, you'll actually see that meibum expression is quite slow, or you might get like a thickened kind of keratinized almost appearance of the meibum. And you'll have to press pretty firmly on the glands and on the lower lid margin to get any expression of the meibum. And that in itself is abnormal. Our blink reflex is what helps to control the expression of the meibum from these glands. And so if you're having to push really hard to be able to express any meibum, then they're likely not getting any flowing. So the quality of the meibum that's expressed and also the ease of the expression of the meibum are important components of the clinical exam. And then you can also do meibography, such as in this photo here, where you can visualize the meibomian glands. You can do the upper and lower. It's often much easier just to image the lower ones. And then this again can be a metric that you follow going forward in terms of the lipid component of the tear film, which is the meibum that's expressed. So this is also a really essential part of the clinical examination. So when we used to think about dry eye disease, we talked about two very separate forms of dry eye disease, where you have aqueous deficient and evaporative dry eye disease. But now we think about them more on a continuum where patients have components of both, with the majority of patients being more evaporative dry eye disease. And so when we start to then treat this, that's when we start to think about treating the evaporative causes, so improper expression of the meibum, and then also aqueous deficient, so not producing enough tears for that mucoaqueous layer. And that's why it's important to treat all components. And one thing that I'll often speak about with my patients is that it's not just one thing that's going to get you feeling comfortable again. It's often a series of things, and we need to find a routine that works well for you. And we also need to find a treatment plan that works well for you to help with the symptoms, because there's not one reason why the eyes are dry. It's likely a combination of a few different things. And then everybody somewhat exists on the scale of evaporative to aqueous deficient. Some people can be on one end of the scale more so than the other, but it's often a mixed component. And so really the management is to restore that homeostasis of the ocular surface, to improve the quality of the tears so that they're not evaporating so fast, and then also decreasing the inflammation that exists on the ocular surface. Lastly here, neuropathic pain is something that we're really starting to have more understanding about. This is that perception of pain in the absence of any tissue damage. So when you do your vital dye staining, when you look at the tear breakup time, all things appear normal when you look at the meibum expression, etc. But patients can sometimes bitterly complain that they're having discomfort on the eyes or pain. And this is what we don't necessarily classify as traditional dry eye disease, but more so of a neuropathic pain or a keratoneuralgia. So this pain of the cornea. And we sometimes treat this similar to how we would treat dry eye disease and underlying inflammation, but there are specific therapies that tend to help these patients better than your classic therapies for dry eye, especially if they don't have many signs of dry eye disease under the slit lamp. So these patients often require more specific therapies, including gabapentin. Botox sometimes in and around the eyes can help, especially if there's a real blepharospasm component and a significant amount of strain. Alternative therapies as well, such as counseling to really help them have discussion around pain and other chronic pain syndromes. And sometimes even meeting with a chronic pain specialist can be helpful for these patients. Also, ocular surface treatments can sometimes be beneficial. So I'll often talk to my patients about using those, but that their pain is really out of the realm of what's normal for dry eye disease, and that they might require more specific therapies or longer term treatment. So now that we have a really good foundation for dry eye disease, we need to start to have a framework for how to treat it and really coming up with specific treatment plans for the patients based on one, their symptoms. So if they have mild, moderate to severe symptoms, and then if there's a presence of keratoneuralgia or this pain without stain component. And then lastly as well is treatments that they might be open to and specific for their form of dry eye disease, whether it's more evaporative versus aqueous deficient. So I tend to organize my treatment approach into 4 different categories. And I find that helps me organize, especially when newer therapies become available. And it also helps my patients determine what therapies might be more beneficial for them. So I organize it into 4 classifications. The first are the dry eye basics, which I recommend in general to all of my patients. And then we have prescription therapies, in-office procedures, and then lastly, more advanced therapies and things that we can try when patients are refractory to other treatments. So the basics that I recommend to all my patients include artificial tears. And because we know a large component of dry eye disease is mostly evaporative, I always recommend a lipid-based artificial tear. So there's a number that are available over the counter. And I usually recommend preservative-free based artificial tears as well, just because patients are often using these frequently. And so limiting the amount of preservatives on the surface can be beneficial. I'll also ask them to do gels or ointments at nighttime, especially if there's a component of nocturnal lag ophthalmos. And you can assess this at the slit lamp, where if you ask the patient to close their eyes just naturally, so not firmly closing, but just naturally, if they were going to gently close their eyes, sometimes you'll see a lag ophthalmos component. And you might also see inferior staining of the cornea more prominently than elsewhere on the cornea or conjunctiva. So gels or ointments at bedtime can help with that. I talk to all my patients about doing warm compresses, and this is best done with an eye mask, which will really retain the heat well. Doing it with the eye mask can be better because it's a dry heat, which you can microwave, or they have masks that you can plug in with a USB to heat up, rather than doing it under hot water, because sometimes the wet component can irritate the skin, especially if somebody is doing frequent compresses. So that's just one tip. And then lid scrubs are essential as well to remove any bacteria, pollen, dust, debris that builds up over the course of the day. If patients have a significant ocular rosacea component, then I'll recommend one based with tea tree oil. And Demodex is always something that we look for at the base of the lashes, and that's often the cylindrical scurf that can occur. And if a patient has Demodex, then a tea tree oil-based cleanser is really recommended as well. There's a new drop that's coming out that's going to be prescription-based therapy for Demodex blepharitis. I believe it'll be available in the next year or 2, so we'll keep our eyes kind of peeled for that therapy as well. And then lastly, I speak to all my patients about their environment. So if they're working in an office environment that might be quite dry, as well as their environment in their homes, especially as we get into the winter weather, as people are turning on their radiators and heat, that can sometimes dry out the air. So sometimes I'll ask patients to use a humidifier, especially beside the bed, which can help with the air quality in the home, or you can get small ones that you can leave on the desk if you're working long hours on a screen. I talk to patients about diet as well. There's some mixed evidence for using omega-3 supplements. Again, for patients, I say, it's something that you can try if you think it really does make an improvement in terms of your symptoms, then you can continue. But if you don't see much improvement, then to maybe come off of them. The only reason being is that they can be quite expensive for supplementing for omega-3s. But I do talk to patients about getting that naturally in their diet through fatty fish, through flax, or other sources. And then sleep is an essential component as well, and limiting stress, which I know can be difficult to do, but it is worth discussion with your patients. And then lastly, cosmetics. Different cosmetics can cause a lot of irritation of the ocular surface. This here is an example of a patient that has eyelash extensions. And because of the eyelash extensions, the glue was causing irritation to her eyes and to her eyelids. And she wasn't washing around her eyelids and lashes because she was afraid that it would disturb the lash extensions, which she had paid a significant amount of money for. But you can see here, there's a lot of buildup, a lot of kind of blepharitis, flaking of the skin, and a lot of irritation from the lash extensions. So going over again, kind of cosmetic procedures with patients can be helpful to really determine the cause as to why they're developing symptoms. Another thing to consider is the use of topical retinols around the eyes, because retinols are extremely drying. They're found in a lot of cosmetic creams and then also prescriptions for reducing the appearance of wrinkles. So speaking to patients, if they're on a retinol, that can really lead to drying of the meibomian gland. So that's something that patients can avoid for use around the eyes. And then always asking patients to remove their makeup before bed is really important as well. So once we've gone over all the basics with the patients, then I start to introduce some prescription therapies. So there's a number of prescription therapies available, and I think about these in terms of flare-ups for dry eye disease and then your chronic maintenance for treating dry eye disease. So oftentimes for dry eye disease, we get these flares where patients will have a number of good days and then they have a significant amount of bad days. And that can come about due to changes in the environment, changes in, stress, if they've been flying on planes, a lot of screen time, et cetera. And so if they are getting a flare up, then that's when I'll often recommend a short course of a topical steroid. And we do have one that's FDA approved for use for dry eye flare ups. It's a loteprednol based eye drop. And this I found very beneficial for my patients, especially when they come in complaining of acute symptoms. Then we have our more longer term dry eye therapies, and we have cyclosporin 0.05%, or we now have in 0.09% drop that's available. We also have lifitegrast 5%. So these drops work in different ways, but they all work to increase the production of tears on the surface of the eye. So this is a more long-term therapy. I think the thinking in the past for prescribing these was that if somebody failed basics first, then you would start to think about doing a prescription drop. But I really urge you to consider what we discussed at the beginning of the talk, that dry eye is an inflammatory condition, and we need to break the cycle of inflammation on the surface of the eye in order to get the patient more comfortable. So often in needing to do that, that's when we need to start to think about some of these prescription therapies. So rather in the past when we might have waited to prescribe something, these therapies are readily available and covered by most insurances. So I really do urge you to talk about prescription therapies with your patient sooner than later, and especially utilizing them in a more kind of consistent treatment plan for patients. And then lastly, the use of oral tetracyclines can be beneficial, again, especially if there's an ocular rosacea component. I'll often start at a higher dose initially, so like 100 milligrams for about a month daily, and then go down to 50 milligrams daily for 2 months. So a 3-month course or so is generally what I find beneficial for my patients. And especially if they're getting a significant amount of MGD, recurrent chalasia, or if there really is this ocular rosacea component, using this for more of an anti-inflammatory effect can be beneficial. So these are kind of different options in terms of dry eye therapies that you can try. And again, really introduce these to your patients sooner so that they're not suffering with inflammation, waiting for that to get better. Really, you can get to the root cause of the inflammation and treat it with prescription therapies. And then procedures is the next thing to discuss. So procedures can be offered to patients in office, and I found an extremely high rate of success utilizing these procedures. And also patients are very, very open to procedural things that they can do in the office. So meibomian gland expression, I have experience with LipiFlow in my office. There's also iLux and TearCare, so there's a number of different ones that are available, all with pros and cons for utilization. But what these can do is they can help with the meibomian gland expression. And what I tell my patients is that it's almost like how you can brush your teeth every night, but you still need to go to the dentist to get the plaque cleaned off your teeth. It's similar to the meibomian glands in terms of, one, removing biofilm that exists on the surface, and then two, also clearing out those meibomian glands so that new healthy oil can be produced. So meibomian gland expression can be really beneficial. And I do that often in combination with blepharoexfoliation, which helps to remove, as I mentioned, that biofilm around the lid margin and at the base of the lashes. And that again can increase comfort for patients. IPL, or intense pulse light, is something that we've borrowed from dermatology. For patients that have a significant ocular rosacea component, IPL can be extremely beneficial for them. And there's ocular therapies and protocols that exist. Punctal occlusion, I have a number of patients that really like this because it's not another drop or something that they have to add to their regimen. The one thing that I will caution is, because we know that ocular surface disease and dry eye disease is inflammatory in nature, you want to make sure that you're treating the ocular surface inflammation first before doing punctal occlusion, because that in turn might lead to increased inflammation and inflammatory markers on the ocular surface if you place the plugs without treating the underlying inflammation first. So sometimes I'll do a short course of a steroid, or I'll start a longer term prescription therapy first, have them come back and then add punctal occlusion second. And again, that can be really helpful because then it's not another drop that a patient has to add and do on their own. And it's just something that you can do in the office. If patients really like these, but they're continuing to fall out, then I would recommend punctal cautery for your patients. And then lastly, superficial keratectomies can be beneficial if there's a component of epithelial basement membrane dystrophy, or if there's Salzmann's nodules and there's a real visual component to the ocular surface. Then sometimes doing a superficial keratectomy can help. And sometimes I'll do that in combination with like an amniotic membrane graft at the time of healing to just increase healing of the ocular surface. So those are going to work for the majority of your patients. And there is a very small subset of patients that have very advanced dry eye disease. And this can be due to a number of reasons. It can be due to autoimmune conditions that are, poorly controlled. It can be due to past graft versus host, multiple things that might lead to more kind of chronic changes of the ocular surface. So there's a few different options for these patients. You can try things like moisture goggles, which can be worn during the day. Serum tears as well. These often have to be compounded, but this can be extremely beneficial. You can do anywhere from a 20% to a 50% component of the serum tears. I'll often do these 4 times a day for about 3 months and see if there's any benefit. Contact lenses, which are specialized for ocular surface disease, including scleral lenses, pros, or bandaged contact lenses, again, can be really beneficial, especially if people have more chronic changes to the surface or to the lids that need to be managed. Amniotic membrane, as I mentioned before, you can do in conjunction with the superficial keratectomy, or if there's a significant amount of ocular surface disease that needs to be treated, then you can use amniotic membrane as a rehabilitation as well for the surface. And then lastly, oral secretagogues can be helpful, especially if there's a component of aqueous deficient, or if they're on the scale towards aqueous deficient. So I just want to kind of put this as a plug for treating these patients. When I was training, and it was always kind of frowned upon for dry eye disease, we didn't have many therapies available to offer patients, and some of these patients can be very challenging. But I just want to let you know that treating them can also be extremely rewarding. I've had this is just a letter that I received from a patient, and she was so happy with the improvement in her vision and the improvement in her dry eye symptoms. So I know it can seem overwhelming in terms of treating these patients, but I do urge you, if you have an organized approach, and especially kind of organizing your treatment strategies into those 4 categories, and then really kind of picking and choosing what's going to be appropriate for each patient, involving them in their care, I think that you can have like a lot of success in treating these patients. And the one thing I would urge you is really get to the root of that inflammation, prescribe early. You don't have to wait, many months for patients to fail basic therapies. We have a number of therapies available now. So examine at the slit lamp, think about kind of a customized treatment plan for that patient, and prescribe therapy soon because they can be really beneficial. So thank you, and happy to hear from any of you if you have any questions about dry eye disease or treatment options going forward.
Excellent. Well, welcome everyone here. That was a fantastic talk by Dr. Ashley Brissette on dry eye. And we have Ashley here with us live for a live question and answer. So thanks so much again, Ashley, for being part of it and for a wonderful talk. Anything that you want to pass on, just some general talking points after your excellent talk?
Yeah, the one thing that stands out to me, we recorded the session a few weeks ago. So there's one product that I didn't include, but that I'm really excited to talk about and to trial in my own patients. So we have a lot of drops that are prescription therapy drops for dry eye. But there's now a new prescription nasal spray, which is varenicline medication, which activates the trigeminal nerve, which is in the nose. So it's a nasal spray that you use. You kind of point it to inside the nose, but rather than going up, you point it towards the ear. And when you spray the nasal spray, it activates those receptors in the trigeminal nerve, and it causes an increase in tear production, basal tear secretion, and you also get some expression of oil from the meibomian gland. So it's almost like a complete tear that's getting created, and it's used twice a day. So again, just another option to consider, especially if patients are already on a prescription therapy and they maybe failed it and they haven't had great success. This works in a totally novel way. And I'm also interested to see how this starts to play out in maybe new dry eye disease patients that maybe they haven't even tried another therapy yet, but it's just something that you can even start as a first-line therapy rather than thinking about using something in terms of an eye drop. So again, just really novel, interesting ways to start treating this disease. And I think it really speaks to the complexity of the disease and thinking about this as a disease process where you're not just saying, try some artificial tears and I'll see you back in a year. There's ways to treat it. And as I mentioned in the talk, it's really about getting to the roots of the inflammation to treat that to get patients more comfortable.
Neat. And then, so that BID dosing for the nasal spray, Ashley, is that like you just keep using it indefinitely, like tiers, or is there a period of time that you use it for?
Yeah, I think the studies took it out to 3 months, and they showed improved benefit in Schirmer scores and in patient comfort at the 3-month mark. So definitely for at least 3 months, and then excited to see how it plays out for patients to use longer. Because as we know, dry eye disease, it's a chronic progressive condition. So it's nothing, I always say to my patients, it's nothing that I'm going to completely cure you of, but really the goal is giving you more good days than bad days, and then finding a regimen that works for you. Another thing that's important to know about dry eye disease is these patients get flare-ups of dry eye. So they might be fine for a period of time and then have a big flare-up where they're uncomfortable, scratchy, gritty, blurry vision. And so then learning how to treat those flare-ups on top of their baseline kind of therapies that they're doing is also an important part of the prescribing regimen.
Excellent. And then one question that's come up during your talk today, and that comes up a lot, is, dry has evolved so much, and it's really the way you target it now is really impressive. But for the non-dry eye specialists, whether it be retina or a cataract or neuro-ophthalmologist, because dry eye really is a significant part of all our practices, what would be a top pearl, or maybe a couple of pearls that you'd want to pass on to the non-dry eye specialists about managing dry eye in 2022?
Yeah, I think the main message would be that it is treatable. Often I think we have this perception that dry eye patients are difficult to treat, and there are a subset of them that are really refractory to a number of our treatments. But the majority of dry eye patients, if you can get to that root cause of the inflammation and treat that inflammation, you can get them more comfortable. So don't be afraid to do a short course of steroids. Don't be afraid to look at prescription therapies for dry eye disease. The thinking no longer really exists that you have to do artificial tears for a year and some basics before you start to try prescription therapies. Go right to the prescription therapies because they are beneficial. And even then to start to think about in-office procedures like punctal plugs, meibomian gland expression, microblepharoexfoliation. These are all helpful and ways that you can actually make a difference.
Excellent. And then do you find that, when managing dry eye, is it still one of those that you prefer to be referred for an assessment? Because it sounds like what's interesting is dry eyes become very individualized, patient to patient, rather than like, I feel like when I was a resident, tears for everyone, and then, we'll see what happens after that. But now it seems a lot more individualized. Do you still prefer that approach in these recalcitrant or harder cases to diagnose and create a management plan?
Yeah, I think sometimes these patients really need a little bit of hand-holding, especially early on in their disease process, until they kind of find a regimen that works for them. So if you're finding you have a subset of patients that are recalcitrant or, aren't responding to other therapies, then definitely referring to a dry eye specialist or someone that has an interest in it can be really helpful. Because again, there's more advanced therapies. And I always say to patients, I'm here with you for the entire journey. We're going to start with some things, we're going to try a few things, but it's really different for everybody. And what you respond to might not be what somebody else responds to. So we might be a bit of trial and error before we find your regimen. I think for the majority of patients, they can often be treated once you get to that kind of cause of the inflammation and treat it, that they can get more comfortable and you can kind of get them into a stable process. But for some of these harder patients, definitely a referral to a dry eye specialist might be worthwhile.
And I'm glad you brought up the trial and error. When you're trialing a dry eye therapy, is there a typical time frame, 3 months, 2 weeks before you consider switching, or say, hey, maybe you're not responsive to that? But what's your approach?
Yeah, I definitely consider doing for at least 3 months, especially if you're starting a new prescription therapy, because I always say to my patients, these therapies are working at a cellular level. And so we really have to give them time to work. And you really have to be good about doing all these therapies and be really conscientious as well of the basics practices. So things like hot compresses, doing the artificial tears, lid care is extremely important. I mean, when you think about what we encounter day to day with pollutant debris in the air, with allergens in the air, bacteria that builds up on the lids and lashes, all of that affects the eyes and the comfort of the eyes. And so even just doing those basics at home is an important part of somebody's role in taking care of their own health. I mean, we always say to patients, you brush your teeth every night, you take care of your teeth. You have to learn how to take care of your eyes as well. This starts to become a part of your daily practice and your daily routine. I mean, your vision is your most important sense, I would argue. We're all ophthalmologists. I think we think it's the most important thing. And so learning to really take care of your eyes needs to become a part of your daily habit.
Yeah, that's I think that's excellent advice. And then, as an some of the questions that came up were, if you consider a dry, maybe more difficult dry eye patients, typical factors for either failure or recalcitrance. If you think of patient compliance, let's say cost reimbursement, and then actually pathology or really bad disease, how would you say are those three play into the role? Are most cases just an issue of compliance, or is it more to do with insurance issues and actually reimbursement? What are your thoughts on it?
Yeah, it's so diverse and it's different for every patient, which is why it's so important to talk to them. I mean, I say to my patients, it's also really guided by your symptoms. So if I look and I see, minimal signs of dry eye, but you're telling me you're extremely uncomfortable, then we need to treat that. And the same goes the opposite. If I see signs of dry eye disease, but you're comfortable, I'm not going to force you to do, lots of procedures and lots of prescription therapies. So it's also symptoms driven for me. And so if patients are trialing things and starting to feel better, then that kind of helps to guide in terms of the direction. Insurance coverage is definitely something that you have to consider as well, because some of these therapies can be quite expensive. Luckily, some of these companies do have, help with payment plans for patients, with being able to access these therapies, helping with prior authorizations. My reps that come in have been extremely helpful in helping to secure that for my patients. And so if you do have something that you want to trial, reach out to the reps, get them to assist your office in terms of getting these therapies available for your patients, because it's been really instrumental in being able to provide these services.
Oh, wonderful. Yeah, I know I learned a lot. And one thing I really like about something like Eyes on 2022 is you really get this really, key opinion leaders like Dr. Brissette talking about these topics that, as a retina surgeon, I don't encounter, I don't take deep dives all that often. So I learned a lot. Is there anything else you want to pass on to our audience today, Ashley?
I think just knowing how many new therapies are coming out to treat dry eye disease. I mean, even since I finished my training, so there's more prescription therapies available, more procedural therapies that are available. I mean, dry eye might not sound that sexy to many people, but I think it's kind of an interesting disease. And I think that there's so much more available for us to offer our patients, makes it a really exciting time to start to think about treatment and maybe making this a part of your practice.
Oh, wonderful. Thanks so much, Ashley, for your clinical insight, for really imparting so much knowledge to us. And we really appreciate your time, and the audience thanks you as well. So, and then just a couple of housekeeping here before we transition. Just please be sure to visit the exhibit hall, where you can live chat with team members from 22 different companies. And really just like an in-person trade show, you can visit exhibitor booths, check in or speak with any company representatives, download information, request information. This free event wouldn't be possible without our sponsors. So please take a moment to visit their booths, say hello, chat, build new relationships, or get informed on all the dry eye therapies that are out there that Dr. Brissette mentioned. There's a brand new innovation zone where product, services, and ideas are highlighted as potentially changing the future of eye care. So be sure to check that out. And then be sure to check out Jessup Cellars. It's a little bit too early here to be drinking on this, but that's the official wine of eye care. So stop into their booth and view their wine collection. Pick up a bottle to join us for a drink later on. So thanks again, Dr. Brissette. Really great to see you again, Ashley. And
absolutely. And everyone, feel free
to
reach out if you have questions. Reach out on social media. I love meeting new people and interacting. So would love to hear from you guys.
Also, and where can we find you on social media, Ashley?
Yeah, so on Instagram, I'm at Brissette MD, and same on Twitter. And then same on Facebook. So you can find me at the same handle everywhere.
Well, Brissette MD, perfect. Thanks again, Ashley.
Thanks,
and thanks for everyone for attending the talk.